that in children at least, disruptive behaviors are fairly low. Where we start to see them come to play would be in late adolescence, early adulthood. So in new onset behavioral disturbances, including aggression and Down syndrome, we want to make sure that there are no medical issues that we're missing. Some of the things that we would put a red flag on: if there are recurrent hospitalizations, if there are pre-existing or active seizure disorders, hearing or visual impairment, gastroesophageal reflux or esophagitis, any sort of pain, earaches, toothaches, muscular aches and pains, a primary sleep disorder even without apnea, or obstructive sleep apnea, and some kind of thyroid dysfunction. Now, there is a proneness towards low metabolic rates in the Down syndrome population, some of which will be related to overt hypothyroidism. Also, any new onset behavioral disturbances could also be related to psychiatric issues. In the pre-pubertal group, we want to think about ADHD, oppositional defiant disorder, and autistic spectrum disorders. And also in the post-pubertal, we want to think about depression, obsessive compulsive disorder, and even psychosis. So some medication guidelines that were proposed by Capone and colleagues in 2006, that for the oppositional defiant picture that also includes physical aggression or destructiveness, the initial consideration should be an atypical neuroleptic, again probably risperidone, and other considerations after that would be a mood stabilizer or a beta-adrenergic antagonist such as clonidine or guanfacine. There are some other medication guidelines for other presentations such as depression and psychosis. Okay, what I'd like to do now is to switch gears and to talk about self-injurious behavior. Self-injurious behavior can be just as disturbing for those that are experiencing it as well as those observing it, because it really is aggression towards the self. And also, just like aggression, it can derive from any number of causes, either singly or in combination. So we have to put our thinking caps on, do a good evaluation, both medical and psychiatric, to try to figure out why this person is hurting him or herself. Developmental syndromes also are overrepresented in the rates of self-injurious behavior, and the ones I'm going to talk about are Prader-Willi syndrome, Fragile X syndrome, autistic spectrum disorders, Cri-du-Chat syndrome, Smith-Magenis syndrome, Corneal-de-Lange syndrome, and Lesch-Nyhan syndrome. As far as Prader-Willi is concerned, most patients with Prader-Willi will have some sort of self-injury, and mostly consists of skin picking, and not surprisingly, it's the places that they can reach most easily, and that would be their legs, face, and arms. However, other types of self-injury, such as head banging, can be seen. So this chart by Didden shows that as far as body parts involved, 75% will involve the arm, 59% the leg, and 41% the face. And even some unusual areas that were really more disturbing. For example, about 5% will show picking in the genital area. As far as the percentage of individuals showing self-injurious behavior, the mild to moderate range percentage, scratching is fairly common, and any scratching will be seen in about 32%, all the way down to ear picking about 3%. So besides scratching, the numbers of people involved in this kind of behavior will drop, but if it's only 1 or 2% and it's serious, it's a significant small number. So how do we treat the self-injurious behavior in Prader-Willi syndrome? Because there is a strong obsessive-compulsive flavor or component to self-injury in this group, medication treatment should begin with an SSRI. And if 2 reasonable trials with an SSRI have not been effective, low-dose risperidone may be helpful. There was one study in adults with Prader-Willi syndrome that showed quite a bit of reduction in skin-picking behaviors with the use of topiramate. In younger people, because there's not data on that, we might want to consider that if other treatments are unsuccessful. It should be divided twice daily, as renal clearance in this population is increased in pediatric patients. The next syndrome with self-injurious behavior is Fragile X syndrome. Onset of self-injury in this group tends to be early on in life, and it's modestly correlated with other problem behaviors. In 2008, Hall found that self-injurious behavior occurred in about 58% of boys, 17% of girls with Fragile X syndrome. And also compulsive behavior had fairly high rates, 72% in boys, 55% in girls, and did not appear to be associated with the self-injurious behavior. So looking at the prevalence and forms of the self-injurious behavior, we see that the people hitting themselves, 16% or so of boys, but none of the girls. Biting oneself, a little over 45% of the boys, and not quite 7% of the girls. Pulling the hair about equal, about 3% or so. Rubbing or scratching, a little bit higher in the boys. And eye poking, neither one. So really, biting the self is a biggie, and hitting the self, especially in the boys with Fragile X. So treatment is really hopefully geared primarily in a behavioral way, but if that is failing, that we can usually combine the behavioral interventions with some sort of pharmacologic agent. And again, thinking about comorbidity. So if we think that there's ADHD, we would treat that, depression, etc. In the autistic spectrum disorders, in a study that was done by Bagdadli, over 200 autistic children that were under the age of 7, it was found that 50% had self-injurious behavior, and almost 15% it was to a severe degree. And that was defined as, quote, functional or life-threatening lesions. So this is really major damage done to the self. Some of the risks were younger chronologic age, associated perinatal conditions such as perinatal hypoxia, higher degrees of autism and autistic features, and also higher delay in achieving daily living skills. All were correlated with increased rates of self-injurious behavior. So these kids were fairly impaired. Unfortunately, the self-injurious behavior is not necessarily outgrown. In 2000, Bodfish found that when compared to adults with mental retardation without autism, almost twice as many of the autistic adults displayed self-injurious behavior. And again, the severity was also greater in the autism group. So that's a huge risk factor for self-injury. And when they compared the individuals with autism and mental retardation, and each of 6 repetitive behavior disorders, we find that the self-injurious behavior approached significance at the 0.075 level. As far as stereotypy, self-injurious behavior and aggression, in comparing autism and mental retardation, there was a fairly high degree of correlation of 0.028 comparing the autism, which was higher in self-injury than those with the mental retardation. And interestingly, there was no significance between aggression in the two groups. So as far as treatment in the autistic spectrum regarding self-injury, risperidone has been found to reduce self-injurious behavior in the autistic spectrum. And so I think risperidone should be the first medication of choice, but with some cautions. Number one, even though the frequency of autistic-related self-injury was reduced, duration and severity of the episodes were not significantly altered. And then the other thing has to do with the weight gain and obesity and other issues related to metabolic syndrome that we see in the atypical antipsychotics. In the event that the self-injury in the autistic spectrum doesn't respond to the antipsychotics, or if the medications are not tolerated, the opioid antagonist naltrexone may be beneficial. As I mentioned very early on, the UK group did not find any significance in the one RCT that they looked at, but Elchar in 2006 did another review and did speak to its effectiveness in some cases. The next syndrome is Cri du Chat. Very, very common to see self-injury in this group. with many, many different kinds of behaviors, either hitting or banging